thank you everybody for joining this webinar. We're really pleased to see there are so many people here online. I'm Claire Sir. I'm Professor of Dementia Studies here at Leeds Beckett University, and I was leading this project. I'm going to let the other members of the team introduce themselves.
I'm Alice Griffiths. I'm a research fellow here in the Centre for Dementia Research, and I was involved in data collection and analysis for the project, but also was the PPI lead.
I'm Rachel Kelly. I'm a research fellow here as well. I used to work as a nurse with people living with dementia, and like Alice, I was involved in the data collection and the analysis for the study.
And just to mention that we are presenting on behalf of the wider research study team, so there are quite a number of other people involved in the study that we'd like to acknowledge, and the logos, I think, are on one of the later slides. So this is just a quick overview of what we're going to cover in the webinar today. We're going to look at why dementia is important to think about in cancer care. Alice is going to talk to you about how people with lived experience of cancer and dementia were involved in our project. We're going to give you an overview of the two linked studies that were part of the bigger project and the results from those. We're going to focus on the findings and in particular the practical steps that people working in oncology services can take to support people with cancer and dementia. We'll talk to you a bit about how we're going to share the findings and what our plans are so far, but we'd really also like to hear your views on how you'd like us to share the findings, the formats that you'd like those to come in, and obviously we're happy to take any questions throughout the webinar. So if things you want to ask, if you want to type them into the box, and then we will answer those at the end of the webinar. If there's any we don't get time to answer, we will hopefully be able to download those and answer them electronically later. So just to give you a bit of an overview about why we did this project, why is it important to consider dementia in cancer care? Well, both dementia and cancer are conditions where there are a significant number of older people affected. So there are 850,000 people in the UK who are living with dementia, and that number is predicted to rise quite significantly by 2051 to over 2 million people. Quite a lot of those, or the majority of those people with dementia, are older people, so age 65 and over. And we also know that for cancers, about half of cancers are diagnosed in people who are aged 70 and above. So we've got two conditions here that affect people in older age, but what we don't know is much about how many people are affected, what that population looks like, and what their experiences of cancer care for people with dementia are. Going on what we know about the experiences of people with dementia generally in hospital care, we know they tend to have poorer experiences and poorer outcomes. So we thought that probably might be part of the experience of people with dementia accessing cancer treatment and care, but of course we weren't sure about that, and actually there might be things that are going on in oncology services that we could learn about to spread into wider care for people with dementia in hospitals if there's lots of good practice going on. We also don't know how many people have cancer and dementia, so there are a wide range of studies that estimate this from studies recruiting just people with cancer or dementia, and they ranged from 3 to 19%, so that's quite a wide range really. So we wanted to try and be able to narrow that down and to be able to give a more accurate figure. I'm going to hand you over to Alice, who will talk about how people with direct experience of living with cancer and dementia were involved throughout our project.
There are several ways that people were involved who'd either had direct experience caring for someone with cancer and dementia, or they had both conditions themselves, or supported people with these conditions. So we had an individual who'd cared for her husband with both conditions, who was a co-applicant on the application, so she was involved from the very beginning of the project. We also had the lay advisory group, which consisted of a person who is currently living with dementia and has previously had cancer in the past couple of years, and people who had provided care for someone who had both of these conditions. We also had a physiotherapy student who was studying here with a special interest in older people, but she qualified halfway through the project, so she left the group at that point. Also, on the project management group, we had 2 people from the lay advisory group who attended all of these meetings. And the reason we had 2 is following the Alzheimer's Society guidance that you should never just have one person in a larger meeting representing a lay perspective. So the lay advisory group met 6 times over the 18 months, and we were in contact regularly with them in between those meetings. In terms of what their involvement looks like, they designed the information sheets with myself and Rachel. We got together the information that was required from an ethical point of view, but also the information that they felt was important. Designed these together, then we went away and put it all together and took it back for them to look at. They really provided us with lots and lots of recruitment strategies that maybe we hadn't thought about. So things like individual charities that they'd worked with, some work with the Alzheimer's Society Forum, and also lots of suggestions for how we could engage with people on social media and what kind of people we should be tweeting towards and where we should be aiming our study adverts. They also co-developed the interview guides with us. So Rachel will talk a bit about the study 2, where we did interviews with people, but those guides were really developed in the lay advisory group meetings and put together as a group, and then we went away and typed them up. A few of the members also did data analysis with us. So for this, we'd send transcripts over for them to read, and they'd bring them to the meetings with us, and we'd go through them together and think about what kind of themes were coming out, whether they matched with their experiences, or anything that was really surprising to them. And finally, for dissemination, they gave us lots of ideas of places we could go for non-academic dissemination, and also some specific dissemination forms that they thought were really important. This infographics was a huge one, and we have one woman in particular on the group who felt that she had a lot of expertise around that and really wanted to get involved in that. But also they felt as a group that they really enjoyed seeing videos as a way of disseminating research findings, and also having some specific case summaries of individuals that we'd recruited and collected data from in the study, so that we could have that kind of real life perspective for people to see. So in terms of what worked well and not so well, we're really lucky that we had a confident group who bonded well together, and they were willing to give their thoughts and opinions openly to us. They were happy to disagree with each other. They were happy to have a kind of debate to help us understand the different perspectives that people might have. Initially, we found it quite difficult to recruit to the lay advisory group. It was quite hard to identify people who had both conditions. We work quite closely with quite a few charities that support people mainly with dementia in Leeds and West Yorkshire, but lots of them were saying that they weren't supporting anyone with who also had cancer or who also cared for someone with cancer. Retention was also an issue, so we had changes in some people's personal circumstances, which meant that they left the group throughout the 18 months. And finally, meetings was something that worked well and also not so well. So travel could be difficult. As we had difficulty recruiting people initially, some people had to travel quite some distance to come to the meetings, and we had snow one day, which was problematic, and for a lady with dementia and cancer, it meant that she was supported by a researcher who met her at the train station. They travelled together. In terms of supporting people, we had Skype or phone options available if anybody didn't want to come in. We made sure that we had really simple agendas and minutes, and we had a special focus on reflecting on something that had been highlighted, so you said, and then what we did in response to that. And also we made sure that we had regular breaks throughout every meeting, so they were normally 2 hours, but we'd have at least 2 breaks to make sure that everybody had enough time to get to the toilet and get a drink, and also something to eat sometimes.
So now we're going to move into telling you a bit more about the 2 interlinked studies that were part of this project. So our overall aim for the project was to identify the cancer care needs and experiences of people who were living with both cancer and dementia. And under that umbrella, we had 1 qualitative study and 1 quantitative study. It was funded by NIHR Research for Patient Benefit, and you can see the team of people who took part there. So we'd like to particularly mention our colleagues from the University of Leeds, from Birmingham City University, and the two NHS trusts we'd really like to thank for being involved and supporting us all the way throughout the project and into dissemination. And you can see the names of our lay advisory group members on the screen there. So study one, this was our quantitative study. And this is a study where we wanted to look at what does the population of people who've got both cancer and dementia look like in terms of their size, in terms of their characteristics, and in terms of the clinical and service use that they have, particularly compared to either people with cancer alone or dementia alone. So what we got to be able to conduct this study was a large data set from Research 1. So this is an anonymised data set that comes from System 1 GP practice records. Not every GP practice that has System 1 also lets their data go through to Research 1, but our data did include 391 practices. They were spread out across the UK, although there is a larger proportion across the Yorkshire region. And that accounts for about 5% of UK GP practices. And what we asked for was data from the period from 2005 to 2016 for anybody who's aged 50 and over and who had a QOF, so a Quality Outcomes Framework, tick box on their GP record of a diagnosis of cancer or dementia or both. So that gave us a really large data set to work with. And this is the size of the data that we were looking at. So we've just summarised here the people who are aged 75 plus because this was the highest prevalence of both cancer and dementia and both conditions because of the numbers of people obviously affected as people age. So we had nearly 42,000 people who just got cancer, just under 42,000 who just got dementia, and just over 3,000 people who were living with both conditions. So that gives us 7.5% of people who are aged 75 and above who have cancer also have a diagnosis of dementia. And it actually also worked out that 7.5% of people aged 75 plus living with dementia also having cancer. So that's 1 in 13 people of either of those groups. If we think that there are quite a number of people who don't have a formal diagnosis of dementia, so dementia diagnosis rates range between about 60 and 75% across different areas of the country, we're probably looking at more like 10% of people who are living with cancer also have a diagnosis of dementia. So that's quite a significant minority of people. And so it definitely warrants consideration within oncology services of the needs of people with dementia. This isn't a small number of people, this is quite a significant number. So what else did we find out about the people in our study? So where were people living? So this graph shows a comparison of people with cancer alone, dementia alone, and then the combination of the two. And the dark blue bar shows what percentage of those were living in a care home. Now, we do have to have some caution around these figures because the data is anonymised. There is a sort of way in the system that it predicts whether somebody is living in a care home based on postcode and the name of their address, and so that looks likely to be a care home. So there is some caution around these. And also because we've got 10 or 15 years of data on some people, it's not that they were necessarily living in a care home for the whole period. It's at a point in time, the most recent point in time where they were living with a cancer and dementia diagnosis. That's the point at which we took their address. So it's people at some point in their journey with these conditions. But you can see we've got over 40% of people with cancer and dementia living in a care home. So the population are looking much more like people with dementia alone than people with cancer alone in terms of where they are living. In terms of the types of cancer, we've got people with cancer alone in the left-hand bar and people with both cancer and dementia in the right-hand bar. And you can see there's slightly more people with breast cancer who've got both conditions. There's a bigger proportion of people with prostate cancer with both conditions, slightly smaller number with lung than the people with cancer alone, and a few more with with bladder cancer who've also got dementia, but other percentages looking roughly similar. So that's got implications for people working in specific services within oncology, particularly breast, prostate and bladder cancer. We need to be thinking perhaps more about people with dementia in those clinics than in some of the other services. But it doesn't mean we don't need to think about the needs of people with cancer and dementia right across oncology services. In terms of comorbidities, what you can see from the last bar on the chart is that people who've got cancer and dementia are much less likely to have no comorbidities. So as well as already having cancer and dementia, they're much more likely to have 4 or more comorbidities than people with dementia alone or cancer alone. So these are a population who are particularly complex, not only because they've got cancer and dementia, but because of the wide range of other conditions they've got. So we really need to be thinking about that as well in terms of their treatment and care, the sort of complexity and the likely frailty of this group. And finally, health resource use. So this looks at primary care appointments and numbers of prescribed medications. The secondary care contacts and referrals data was slightly less comprehensive in the GP records, so we're treating those with a bit more caution. But what you can see is that people with cancer and dementia do have more primary care appointments than people with cancer or dementia alone, but it's not double, so it's not the same as adding the appointments of dementia alone and cancer alone together. So it may be that they're actually missing out potentially on some of the contacts with primary care clinicians, perhaps because they've got both conditions. They've also got more prescriptions on average per patient, probably related to the additional comorbidities, but that obviously adds extra complexity when thinking about potential issues around polypharmacy. So again, a more complex group of people that we need to think about in their care and treatment. So I'll hand you over to Rachel now, and she's going to talk to you about our qualitative study.
Hello there. So this is the second study that we did, which was linked to the first one, where we really tried to understand actually what is it like for people living with dementia and their families when they're using cancer services, what are their experiences like, also what are the experiences of staff who are supporting people with cancer and dementia, and what sort of things can be difficult, but also what works well. And really trying to understand in much more depth than the first study enabled us to do. So that first study gave us a sort of overview of what some of the issues might be, and we used that to think about what can we explore in more detail in the second study. So to do this, we used something called ethnography, which is an approach we use quite a lot because it works really well in getting to the experiences of people living with dementia. It means using observations as well as interviews and as well as sort of conversations to really try and understand people's experiences. So for Alice and I, that meant going to appointments with people so we could see what it was like for people going to appointments, sitting with them beforehand and waiting, going into appointments, asking them questions about it at the time. So it was much easier for people to tell us how they were finding things than just expecting people to remember perhaps a week or two later how they had found their hospital visit. We did interviews with more people and then the more focused observations and going to appointments with a smaller group of people. So overall, we included 17 people living with dementia and cancer in the study, 22 family members, because some people were supported by more than one family member. And then we also included 19 members of staff, and they were staff that ranged from radiotherapists and oncology, so medics, so doctors, and staff working in oncology as health professionals, so nurses as well, through to people who were looking and arranging transport or working on the reception, so quite a range of sort of experiences. Overall, that gave us 37 interviews, so quite a lot of interviews with people talking about their experiences. And sometimes that included more than one person in the interview, so especially for some people living with dementia, we spoke to them and one or more family members at the same time. So it was 50 people altogether that were in those interviews. And then for that more focused bit of data collection where we actually went to appointments with people and watched what it was like, we did that with 10, which I've put there dyads, but 10 groups of people, so 10 people living with dementia and one or more family members. I'll just explain a bit more about how that worked on the next slide. So this just gives you a bit more of an example of where we sort of hung around, if you like. So Alice and I, as I said, would meet people when they got to the hospital. We'd walk through the hospital with them to see how just getting around the hospital was for people. We'd sit and wait with people, which gave us the chance to have a bit of a chat with them about what they were thinking about ahead of their appointments. We would go into appointments, obviously with everybody's consent, with people. So, for example, there, top right is I'm hoping, a picture of a LINAC machine, a radiotherapy treatment machine. So we would go in and see sort of how people were finding those kinds of environments that are quite alien to most people. We sit in on meetings between people living with cancer and dementia and their family and staff to sort of understand more about what kind of things came up, what kind of things got talked about, what that experience was like for everybody there, and just really sort of a variety of different things. So not just radiotherapy and clinic appointments, but some people's visits for chemotherapy and things like that as well. So that just helps to give us a really sort of in-depth understanding of what that experience was like. These are some of the main findings. That yellow box in the middle is really sort of overarching theme, if you like, that came out of the data was just this idea of complexity, of just how complex it is to be managing these two big conditions. And that came very much not just from this second study with the qualitative data, but also from the study that Claire was talking about, that idea that people have just got a lot going on when they've got these two big conditions and quite often other conditions on top of that as well. The boxes that you can see around the edge, those 6 different coloured boxes, sort of really represent the sort of different ways in which that complexity bore out. So the different ways in which things were more complex, or the different experiences that people had. And what I'll do is talk you through over the next few slides some of those with some examples of what people actually said from the interviews or what we saw when we were going to appointments with people, to give you a bit more of a flavour for that. So this first idea about balancing conditions was really this idea about how having these two big conditions or more requires this balancing act between them, and how sometimes the balance between the conditions is really quite interesting. So one thing that really struck us quite a lot was just often how much impact people actually had from their dementia diagnosis. So people talking a lot about how difficult it was to deal with having dementia and how much impact that had on our lives, but quite often feeling that they weren't getting very much support with that particular condition, which was a real contrast to the level of support they were getting from the cancer services. So this first quote on the right-hand side there, where you can see someone saying that once they got their dementia diagnosis, nothing much really happened. But once they found out they had cancer, it all kicked off very quickly. So this whole sort of ream of support kicked into place that wasn't there for their other condition. There were some interesting things around connections between those different care pathways. So how much do your sort of dementia support team and healthcare professionals speak to the cancer support team and healthcare professionals? That was happened to differing degrees, sometimes more so, sometimes not so much. And the idea about how much staff in one service were really sort of aware of what else was perhaps going on for that person and aware of how complex that particular person was. So this second quote here is an example from a daughter saying about her mum that staff didn't always see how frail she was walking in, how confused she was, that she couldn't see so well. They just sort of focused on the cancer side of things, but perhaps didn't see all the rest of that complexity. And we very much saw that having to balance those conditions happening throughout the pathway, so at the point of cancer diagnosis, when decisions are being made, and when people are accessing treatment as well. And we'll go on to talk a bit more about that. So making decisions, for example, as you can imagine, was something that could be quite difficult when someone was living with dementia as well as cancer. There was a lot around who makes the decision, how much the person themselves is involved versus family members and staff. Issues around capacity and consent, how much does the person actually understand about what's going on, whether that sort of bigger picture, that bigger complexity is thought about, and the sort of the burden really that comes with making these decisions. All the way through these next few slides, you'll get a real flavour of how much families were important in supporting people, and you'll see that in this slide here in the coming ones. This quote emphasises that quite well. So this is a daughter talking about her mum with cancer and dementia, where there was a decision to be made about whether or not she had a mastectomy, so whether or not she had her breast removed. And her daughter saying, what would we achieve by having the breast removed? How it might be really quite traumatic for her, but actually at the moment her quality of life is quite good, she's comfortable, she's happy, and very much appreciating that the cancer surgeon in this instance very much took that on board, because he had been very worried that she wouldn't recognise that there'd be this difficulty around how much decision-making is made by her mother rather than her daughter, and how stressful that was, the idea that if she had her breast removed, it would be a really traumatic thing. She might forget on a daily basis that had happened, and how stressful that could potentially have been if she hadn't have been as involved as she was. So the next slide is about this idea of working blind, which was something else that came up very strongly and relates back to decision-making a bit as well. The idea that there was quite often people working without all of the information that they really needed to do that. And that was could be the person living with dementia themselves, it could be family members, or it could be staff. So you can see a few examples of that on the right-hand side. So first of all, a staff member saying, I personally haven't had any training on dementia. And this was quite a common theme, that people felt that they were working with people living with dementia but didn't necessarily have any real understanding as to how to go about doing that. And this could well be, even if in other parts of the hospital perhaps there was lots of dementia training going on for staff, it hadn't necessarily made its way through to the oncology teams. The second quote in the middle here is a son talking about his dad who had dementia, saying that my dad probably gave a very good impression. I didn't really feel it was my place to say, excuse me, but my father can't remember what day it is. So his dad was going to appointments where it wasn't obvious to the staff that his dad actually didn't understand a lot at all about what was being said and what was happening. And his son found it very difficult to say, actually, my dad doesn't know what's going on. The third quote here, from a gentleman living with dementia and cancer and his wife, about sort of how much he didn't really understand about what was going on. So him saying, they don't say it in English, that's the frightening part about it. I cannot understand what's happening to me. And his wife saying, if they had explained it better, I probably would have got him treatment. Quite an interesting example in a couple of ways. So first of all, this gentleman had really struggled to understand information about his prostate cancer diagnosis, and the use of the Gleason score in particular had confused him quite a lot, but just how frightening he found that as a result. He was really worried about what was happening to him and whether or not he was going to be okay. But also interestingly, his wife also, who didn't have dementia, had not understood that information either, and the implication of that was that they had decided not to have treatment, but not because they'd made an informed decision, but because neither of them had understood the options that were being presented to them. The next example here is about sort of navigation and finding your way around both cancer departments physically, but also that sort of emotional navigating through the cancer journey as well, and the sort of the burden and energy that comes with that. So we had examples, as you can see on the right-hand side there, of people having to wait a long time when they were at the hospital, which obviously, understandably, sometimes can't be avoided, but certainly when people are coming in patient transport in particular, really quite long waits sometimes, which could be particularly difficult if you're trying to support someone living with dementia. A son in the middle there saying that I knew from my dad trying to wander off in the car park a few times, I just have to be with him all the time. So actually really quite difficult to physically get yourself and your relative with dementia into the hospital and down to the right department, when you've got to factor in parking the car, at what point do you drop them off? And quite often people not being able to drop someone off and leave them because they wouldn't be there when they come back. That logistics was quite difficult. And then lastly at the bottom there, because of the sort of reliance on family to do that, often on a daily basis if you're going to cancer appointments, just what happens when there isn't a family member. This bottom example was where a gentleman didn't have family to support him, and actually then there was nobody else to fill that really quite big gap. And then lastly, there's this idea of sort of how much the person was seeing versus the sort of other processes that go alongside someone's care when they're accessing cancer services. So as a staff member here just saying how it can be really quite difficult sometimes to find that balance between seeing the person and all the processes that have to be reached, and there can be a pressure to make sure people don't breach, for example, but actually she felt it was much better to give people with dementia the extra time they required. And then lastly, this idea about continuity. So a gentleman with dementia saying you don't see the same doctor all the time, and actually that's really quite difficult because you see different people and perhaps they're going to different places, and it'd be much easier to see the same person more. And lastly here then, we just started to try and capture some examples of things that really worked quite well for people. Alice is going to talk about this a bit more in a second, but just a couple of examples of where, for example, information was tailored for the person. So information was written down so they could understand what was happening and take that away and look at it later. Where appointments were thought about to really meet the needs of the person. So if mornings were more difficult, people would be invited to come in the afternoons instead. And lastly, this recognition about how much families were doing. And so this last staff member saying they really recognised that her daughter was doing such a lot for her mum, and so lots of the support they provided was actually to her daughter rather than directly to her mum. Alice is going to talk in a bit more detail about some of the practical things that we found that cancer services could do.
So firstly, people should be asking about recording and communicating when people have got memory problems. Lots of people felt frustrated that they were constantly having to tell different people about the person having dementia or memory problems and that not being recorded anywhere that was clear. Using pictures and images to help people understand what is going to happen to them and what treatment might look like. So within one of the hospitals we were working, they had lots of photographs of the different machines to show people what this might look like ahead of them going in. Pictures and images and other ways of giving people personalised reminders of their key facts could be really useful, and like Rachel said a minute ago, helps people to give a consistent message across the family. So it might be a picture of lungs with a circle showing where the tumour is, showing the size of it before radiotherapy and the size of it after radiotherapy, so people can see what difference the treatment has made. Including the family, but without excluding the person themselves. So it was really important that consultants and all staff were speaking to the person themselves, but not excluding their family, and also the same the other way around. And it can be really difficult when you've got other people in the room, but ensuring that any decisions being made are being made by the whole family unit rather than people making decisions without fully understanding what's going on. Consistency in staffing and familiar faces was seen to be really key. So can people be treated in the same machine or on the same part of the day unit, or if they're in a small room off a ward, can that be consistent to help them have some familiarity every time they come into the hospital? Also, as Rachel said a minute ago, having flexibility and adaptations for people. So would they suit an afternoon appointment better, and can that be made for them? And are they able to have extra time and support if they're going to be a bit slower getting through treatment than other patients might be? In one of the hospitals we were working with, they have a patient support service, which enabled them to offer a bit more support to people who might need that to get them through their treatment in the kind of least distressing way possible. Another large area is thinking about how dementia-friendly the environments you work in are. So is there clear signage for people that's large and that's not too high or too low, that's at the eye line? Are there relaxing areas that people can sit in if they find the waiting rooms overwhelming? So are there any quiet rooms off to the side where they could wait but staff could come and get them from? Are there activities in there that people can do to stop them getting bored? Things like jigsaws might be really useful, or even just having the music on is better than having a silent waiting room. And is it easy for people to find drinks or any snacks that they might need, or would that involve going back through several corridors to find a vending machine? It might be a place where volunteers could be used to support people when they arrive into the hospital, especially if the car park is quite far away from the department that they're going to visit. And finally, ensuring that staff are trained to support people living with dementia. Not all staff felt like they'd had appropriate training, and they were unsure how they should best provide care to people living with dementia. So some potential ideas for what might be useful. As you can see in the top right photo, it's really clear that there are different coloured parts, which would be easy to signpost someone to, rather than trying to say kind of the second door on the right. These are wards, but there are parts in most departments that could be coloured differently to help people navigate their way around. This Is Me is a document that's available from the Alzheimer's Society that highlights people's likes and dislikes, things that might make them appear quite agitated or things that might make them struggle to get through that experience, that if you were just aware of them as a staff member, you might be able to work with them. And it also helps develop conversations when you know what their likes are, you know what their family history is, you can talk to them about their children or their grandchildren. And finally, recently, an Oxford radiotherapy department has developed a waiting room that you can see in the bottom right picture, which has got several important areas. So they've got large photographs of the local landscapes for people to look at, and they've got lots of stimulating activities for people. So you can just see a few of them on the table there. They've got things like puzzles and twiddle muffs and themed books around reminiscence to give people something to do while they're waiting. And finally, on the left, you can see the Dementia-Friendly Hospital Charter, which talks about what you should expect during a stay in hospital, but can be adapted for outpatient visits and for other departments that people might be coming to regularly.
Okay, so I'm going to talk to you a little bit about how we're disseminating our research, but I just wanted to let you know about some other cancer and dementia studies we've got ongoing at the moment. So these are 3 PhD student studies. Molly Price has been looking at the needs of carers, of people who are caring for somebody with cancer and dementia. She's right at the end of her PhD now. What she found was that carers do need and want specific support, particularly peer support from people who understand and have been in a similar situation to them. And so she's, in collaboration with the Alzheimer's Society, set up a specific forum related to cancer and dementia on their Talking Point online forum. So if any of the people listening in have got people, family carers who might want to go somewhere for peer support, if they join the Talking Point and look for that specific forum, there's lots of Q&As with experts in the area, there's examples, and there's also people chatting about their experiences. And that's going to be maintained and is going to be an ongoing forum now because it's been so popular for the Alzheimer's Society. Olivia is looking at the care and support needs of people who have cancer and dementia in nursing homes. So she's just coming towards the end of her data collection, and Rebecca is just about to start her data collection looking at the same issues within residential care. So we'll be able to report back sometime in the near future about the experiences, particularly of people living in those settings, and given the earlier data that I presented on, around 40% of people at some point in their journey with cancer and dementia are living in a residential or a nursing home approximately. Obviously this is an important issue to consider. So that's just some of the other research that's going on around cancer and dementia within our team. So how are we disseminating our research? Well, we're in full flow with this at the moment, but we'd really like your ideas. So you can either pop them in the chat box now, or if you want to email us after the webinar if you've got ideas, or if you'd like us to come and talk to you, or if you want us to share specific findings with you. The things we've been doing so far are we've been presenting to clinicians in the trust that took part in the study. So we've been particularly Alice and Rachel, are going around to various departments, present the findings, and then actually doing ongoing work with the staff in those departments to think about what they could do differently and how they might improve services. And I think one of the things we've been really impressed with is how receptive the staff in the hospitals and in the oncology departments have been. Dementia perhaps wasn't really on their radar necessarily at the start of this study, but people have been so engaged in the project once it got going and in the findings. We're really finding they're interested in what they can do differently and are really keen to improve people's experiences. We've been contacted by Prostate Cancer UK and are developing some specific materials for them for their website. Around the experiences of people with prostate cancer. The College of Radiographers are updating their guidance on working with people with dementia, so that's for radiographers and radiotherapists. So our research will contribute to the next iteration of that guidance. We're in the process of applying to and presenting at various clinical and academic conferences, both oncology and dementia focused. So we've presented at some already and we'll be doing more of those. We're just about to embark on writing up the papers, so hopefully those will be published next year, and we'll, when those are out in publication, they'll be on our Twitter feed. We tweet about the papers as and when they're published, so if you're interested in those, do watch out for our Twitter account. We're also developing a number of lay summaries and summaries for clinicians and for other groups, so if you've got an idea about a particular group that might benefit from a specific summary of our research findings aimed at them, we're happy to produce those, and we'll be making those available on our website. We're just in the process of updating our website at the moment, so it will contain information about the study and the outputs. We're also writing blogs and things like that to disseminate the findings to various websites. So we'll be doing those over the coming months. Again, we'll tweet about those as and when they come out. So we're really interested to hear what else you'd like to see, or what examples of, if you've got examples of really good dissemination materials you've seen from other studies, we'd be really keen to hear from those, because we want to produce information that's really relevant to the people who need it. So that's our study. We'd really like to say thank you very much, particularly to the NIHR for funding the study, but also to yourself for attending, and to the hospital sites who took part in the study. What you can find there is our website address, but also our Twitter handle there, so and our email address. If you've got any questions we don't answer now, or if you want any information about the study, you can email us or tweet us. But we're now going to be able to take any questions. If you've got questions you'd like us to answer, if you want to type those in the chat box. If you're not sure where the chat box is, if you can get that menu up on the bottom again, you'll see there's a little sort of circle that's got a chat bubble in it. If you click on that, that will open the chat box if it's not already open, and you'll be able to type questions in there. So I think we have one from Tom Rose that either Alice or Rachel will probably be the best place to answer. So Tom's asked, did you come across any good examples of services where mental health and dementia and oncology were working together effectively?
We really did, I think. There were examples of that where people were talking to each other a bit more. I can think, for example, of a lady with dementia and lung cancer, where her consultant was really good at thinking about what was going on with her dementia as well. So getting back in touch with the GP about some issues around that, especially. Another example of somebody where the family member was really feeling that the burden a lot of dealing with these two conditions, and the sort of raft of appointments that come with a cancer diagnosis, but also all the difficulties that come with supporting someone living with dementia. And their consultant put them back in touch with some more support, because he was really struggling with all of that. But there were examples of people thinking about the other condition. But there were also times when perhaps there wasn't as much communication between those two services as perhaps may have been beneficial, I think. I think that's probably fair to say, Alice.
Yeah, and I think it was often people who were providing treatment, so people in the radiotherapy department, for example, who felt that they weren't sure how or where to refer someone who they suspected had dementia, and it was that pathway wasn't always clear. So for people who were already had a psychiatrist assigned to them, or who already were visiting the GP quite frequently, that was much clearer than for when they suspected that someone had memory problems. That was where the issue kind of arose, because they just weren't sure where to send that information to ensure that that person got support.
Okay, so we've got a question from Emma. Any advice for improving oncology MDTs? Often decisions made with neither the patient care or medical team taken when the person's in hospital. Idea would be a patient carer, geriatrician or mental health worker. Might be a little bit more difficult to answer because we weren't necessarily in the MDT meetings where these decisions were made, but I don't know whether you've got any thoughts around that?
Yeah, so something I forgot to mention when I was talking about the second study was, as well as observing people and going to appointments with them and interviewing people, we also, with consent, were given access to those 10 people I talked about, medical records, so we could get a bigger sense of what was going on for people, both sort of when we weren't able to be there and just in terms of things like MDT. So we didn't actually sit in on MDTs so that we didn't hear sort of other patients being talked about that weren't part of the study. But there was certainly felt from the records to be a sense that actually sometimes when people were meeting face-to-face with people with dementia and cancer, they were more aware of some of the issues that people were facing, and particularly the CNSs, so the clinical nurse specialists in the cancer team, provided a lot of support to people. The lung cancer team, for example, were really well engaged with patients, knew a lot about what was going on for them and some of the issues that were coming up, and you could see that in the records with these really detailed considerations, not just around the person's cancer, but also around their dementia and aspects of their cancer care that might be more difficult because of their dementia, and taking steps to think about that. But all of that was not very obvious in the MDT notes. So they were very brief often, and sometimes there were suggestions for treatment that you just felt when you were reading them weren't going to work for that person because of their dementia and other things they had going on. So that we didn't sit in them, but there was certainly a sense that perhaps things could be better from that point of view.
Okay, so question from Denise, have we shared the findings with cancer alliances? No, we haven't, but that's a great idea. So we can certainly produce a study summary that we could share with those alliances. And I'm presuming we're not so, all working from a dementia background, we're not so familiar with all these cancer oncology networks. We do have Laura Ashley on the team who is much more familiar in some of the staff working in oncology services, but we will certainly look that up. Thank you. Alison asks, did you observe or hear that people were being asked what mattered to them?
I'm just stopping to think about that. I suppose, as I was saying before, we heard sometimes that clinicians were taking the extra time to spend with people to talk about their situation in general. So to recognise for some people that actually they weren't necessarily understanding or following what was going on, and that they needed to repeat that or think about saying it in a simpler way. I definitely heard conversations where the wider aspects of the impact of the cancer treatment for that person and because of their dementia were being talked about and considered. So conversations around, actually, we're suggesting this treatment, but I recognise that it's going to be really difficult for you for X, Y, and Z, and having a conversation about that, is there a way that we can make that easier for you? So consideration of what matters to people and in terms of who they want to know or be involved. So consideration in some senses, but not necessarily something that was probably specifically asked or routinely asked. I think our sense was probably that some of these things were quite variable, and it very much depended on whether or not the staff member knew that somebody had dementia or memory problems as well. Sometimes there was quite a lot of conversation, other times there wasn't really any at all, and I suspect that some staff members weren't aware that somebody had dementia.
Mm-hmm. Great. So the next question from Shannon is, will we be looking at needs at end of life? Well, the 2 PhD studies, particularly in nursing and residential home, will be able to focus on seeing people, particularly given the timescale for data collection. There will be some data collection potentially with people coming up to end of life, or staff, and reflecting on how they've supported people who might not now be residing in the home but who previously lived there, how they've supported them through to end of life. And certainly both PhD students are recruiting via and are also recruiting individuals working in palliative care teams out in the community, so they will be looking at that. But Alice, did you want to say there were certainly some people in the study who were not having curative treatment?
Yeah, so we didn't specifically look to recruit people who were at the end of their life, but we had several patients and participants in the study who were receiving palliative treatment, and some of that treatment we observed, and also we, where possible, did interviews with their family and them afterwards, acknowledging that they were having a very different experience and very different expectations for treatment and expectations for outcomes as well.
Great. We've got another question. Thank you, Denise. We'll go through the clinical networks for the Cancer Alliance's contacts. Bindi wants to know, do you know if patients with both cancer and dementia had higher rates of completed advanced care plans, or if not completed recorded plans, were people more engaged in having this conversation?
We're both sitting here shaking our heads slightly at each other, which I think is because we don't really know that. It wasn't necessarily obvious from the information that we had that people were having access to, that had those care plans more. I don't know whether you saw any of that, Alice, but I don't particularly think I did.
No, I can't recall seeing any.
That's clearly an area for people to research in thinking about that, and I think that's the nature of this study. Because there was so little research done in this area, this is the first study to really explore that in the UK, and I perhaps didn't emphasise that enough at the beginning. There's been so little research. There's been a few studies published since our study started, but really not particularly looking at the same areas, a number of reviews of existing literature and some very small-scale studies. So this area is really unexplored. So the idea of this study was for us to identify areas where we either need to do further research or where we could develop interventions that we might want to explore more. So certainly thinking about advanced care planning, particularly if people are receiving more of a palliative or rather than a curative options around treatment, might be particularly interesting to talk about. So we'll see what. Thank you, Tom. Yes, we are on the case with the Macmillan and Dementia UK joint guide on cancer and dementia. We're going to be contacting them to see if they're planning on updating it, to see if we can contribute to that if they are. Tracy asked, is there any specific staff training we're aware of? I don't think, I mean, prior to this study, I did a big study looking at dementia education and training, and I don't recall anything that we came across there that was specific to people with cancer and dementia or for oncology staff. And actually what was happening, particularly in some of the hospitals, even when there is dementia training going on for staff who are working on the inpatient wards, the staff in oncology weren't necessarily aware of that, and we suspect that's probably the case potentially across outpatient departments generally, that the focus of dementia education and training recently in improving hospital care for people with dementia has really been around inpatient experiences. I think our study's shown us it's really time for us to also be thinking about outpatient experiences as well. And so actually one of the teams, somebody in the radiotherapy department, had trained as a Dementia Friends champion and was delivering Dementia Friends sessions to staff who were working in the department. But obviously Dementia Friends isn't training, it's an information session that's actually developed to increase sort of general public awareness about what dementia is. So it's really not designed for staff working in direct care for people with dementia and direct sort of patient care. It really is. What we've got in this country is we've got a tiered framework for dementia education and training. So there's tier 1, which is dementia awareness that everybody in the country who is working in health or social care should have. That covers what is dementia, how to communicate with someone with dementia, so basic skills. And then beyond that, there's tier 2 training, which is much more in-depth, and that is the level that people should be having if they're working regularly with people with dementia. And Dementia Friends is considered tier 0, so it really is basic information to help try and reduce public stigma about dementia and to increase understanding. So really what we need is what's going on in hospital inpatient to be spread out, because there's some really good training going on actually in inpatient, for staff working in inpatient, so we really need to see spread of that. I think the staff who are working in outpatient departments within hospitals. So that would be our recommendation.
Well, I just wanted to thank you for that. It was brilliant talk. It was very easy chairing that talk because you did it all yourself. So thank you very much for that. I think there's so much more we could talk about, and the conversations could really carry on, and so many different areas of us to think about. So I think we're all probably looking forward to reading publications that come out, and I'm sure if you need any of connections, then you can connect through our network to the people who've been on this call, and we can link people up. I think it'd be really good to take advantage of that.
And and we'd really like to hear from people. So if you're working in oncology services and you start to use those findings from our research, or you do anything differently, we'd really love to hear from you, because obviously we can include examples in our presentations as we've done today, and it's just really interesting and important for us to know that the research we're doing is actually making a difference out in practice. And it may be as we take our ideas forward into other research studies, there could be other sites, if you're working in an NHS hospital, that you'd like to take part in future research in this area. If we're aware that you're doing work, we might be able to collaborate or involve you in future studies, so please do get in touch with us. We'd love to hear from people.
Yeah, that's great. So thank you very much.